Welcome to Thursday Thought Leaders with Harbinder Narula from BW Healthcare World, where we bring you the conversations with leading minds in healthcare and well-being. Today, we are diving into the topic that affects thousands every year: head and neck cancers. Joining us today is Dr. Jatin Shah, the head and neck surgeon from Memorial Sloan Kettering Cancer Center, also known as MSK, a world renowned cancer treatment and research institution. We'll explore early signs to watch for, new treatments on the horizon, and how patients can protect their health and quality of life through every stage of care. Stay tuned for a truly insightful conversation. Dr. Shah, thank you so much for joining us on BW Healthcare World. It is such a pleasure to have an opportunity to speak with you. Uh, Dr. Shah, for those who are not very familiar with head and neck cancer, what does it mean? What does it include? What parts of the body does it include?
So I think, cancer is not one disease. Take, for example, we are all humans, but we are not one human species. Each of us has a different name, different ethnicity, different origin, different way of uprising. Similarly, cancers are hundreds and hundreds of different diseases. When I was in training, cancer was considered one disease, and we had one template to treat every cancer. 60% benefited, 40% didn't benefit, and they died. And we still continue to do the same thing. One size fits all. But science has progressed over the years. We now know that every cancer is a different disease. It has its own imprint, it has its own behavior. And therefore, the template may not work because that template doesn't fit the characteristics of that particular cancer, even though, let's say, it's a tongue cancer. Why does treatment work in one patient and the same treatment doesn't work in another patient? And both of them have tongue cancer because those tongue cancers are different diseases. So, what scientists have done over the course of the past 30 years is to identify the genetic and molecular markers of each cancer, to characterize it beyond the diagnosis of cancer. It is cancer, but it has this, that, and so many mutations and fusions, which allows it to be uh, setting its own identity. We are also fortunate now to identify markers and drugs which work on those specific mutations. So we now practice precision medicine. Tongue cancer doesn't mean an operation to cut out tongue in every patient. Some patients need the operation, other patients do not need an operation and can be cured without an operation based on the specific characteristics of those tumors. And uh, we at Memorial Hospital have a in-house developed assay called impact assay, which studies hundreds of mutations in every tumor and gives us a profile of 5, 6, 7 mutations where we have targetable drugs which we can use. Now, so this is at the end of science. At the other hand, the awareness about the disease and the education and the training has changed and improved globally. As I mentioned to you before we started the formal discussion, the International Federation of Head and Neck Oncologic Societies, founded by us in 1987 and closely associated with Memorial Sloan Kettering Cancer Center, has a membership of over 70 national head and neck cancer societies, reaching over 48,000 clinicians treating head and neck cancer around the world from 58 countries. So the awareness has improved, the training opportunities have improved, the presence of the internet has allowed access to knowledge instantly. Something is discovered in New York at 5 p.m., at 6 p.m., you can know about that in Guwahati or in Peru or in New Zealand. So the communications have improved. So all of these things have changed the scenario completely. It is no longer cancer, therefore death sentence, and cancer means terminal care. I should buy life insurance or I should write my will. No longer true.
So this brings me to a point where when we look at the awareness, unfortunately, that somebody who's dealing with cancer or when somebody is detected with cancer, that is a time when they go look out for information, and that is the time when their ability to absorb that information is very different because even when the world tells them that, listen, today we have the treatment available, everything will be fine, there are chances, but because they have never absorbed that information ever earlier in their life, they are hit with this cancer and they feel that now everything is doomed. So
Well, you hit,
is
yeah.
the awareness, what is it that we could do so that people are
Okay.
aware of the benefit of the new treatment methodologies?
So you hit the nail right on the head. Our methodology of treating cancer is reactive. We find the diagnosis and we treat it. What we need to be is we need to be proactive, not reactive. In other words, be aware of the potential risk of cancer. Identify, am I at risk of developing cancer before it develops? And what can I do to prevent it from developing? So that is the focus of modern day medicine. Can we identify in your body, in your system, uh, are there any clues, any messages, any subclinical evidence in your blood, in your cells, in your urine, in your sputum that we can identify and say, you know what, this is likely to going to lead to a cancer. Let's find a way to put the brakes right there before it goes on. So that is the current focus of research.
And Dr. Shah, uh, what are some of the early signs of head and neck cancers that people, both patients as well as the primary care doctors, because people don't go to a oncologist straight away for the symptoms.
True, true,
But
true, very true.
what are the
So I think,
symptoms
yeah.
that patients or the primary care doctors should be paying attention to?
So we all have the habit of what ठीक हो जाएगा. You know, it will go away. Well, it doesn't go away. So if you have any symptom that lasts for more than a couple of weeks, go seek advice. And what symptoms I'm talking about? Cough, uh, flame, blood in the sputum, a sore in the mouth that doesn't heal. Don't call it a canker sore. If it's there for 2 weeks, go see a doctor. A sore on the skin, a lump in the neck. Those are the signs of obvious cancer. The train has already left the station. You are lucky enough to find it before it gets worse. So don't neglect it. Very simple, 4 or 5 things. Cough that doesn't improve, change in your voice, difficulty in breathing, a lump in the neck, sore in the mouth, blood in the sputum. All of these are signs of cancer until proven otherwise. So any of these things lasting more than 2 weeks, you need to go to a doctor.
Got it. Got it. And sir, we are hearing more about the HPV related head and neck cancers these days. How has this changed the way you diagnose and treat these cancers? Uh,
So
has it also changed the way you approach the diagnosis and treatment for these cancers?
yes, yes, indeed. So relatively uh, early, I should say early, meaning in the past 20 years, we have come to know about the association of the human papilloma virus with certain types of cancers in the head and neck area. A HPV, human papilloma virus, is well known to be associated with cancer of the cervix in women. We know that for decades. But its association with cancers in the head and neck area, particularly in the throat, in the tonsils, in the back of the tongue, is a new phenomenon in the last 20, maybe 25 years at the most. And fortunately, it is a disease which is highly responsive to treatment and carries a good prognosis. So it is a new cancer, but it is a new cancer which is somewhat favorable. Now, when it was first introduced into the clinical arena, it was as associated, or at least it was uh, blamed on the practices of your sexual habits, practice of oral sex. But that is not the only cause. Yes, that is one of the causes. And if you are practicing that, you should try to avoid it. But even in the absence of that, you can get HPV associated oropharynx cancer, cancers in the tonsil and the back of the tongue. Usually, these occur in young people, in contrast to cancers occurring in 60s and 70s. This occurs in patients who are in their 30s, 40s, 50s, who are non-smokers, who are otherwise healthy. So they don't chew tobacco, pan masala, or whatever. They don't smoke. They are not alcoholics. They have healthy habit, but they get this cancer. The good news is these cancers, even at an advanced stage, are highly responsive. And if you put all HPV associated cancers together, nearly 85 to 90% of are being able to be cured, regardless of the stage they come in. So, yes, it is a new cancer. It is highly curable, requires appropriate treatment. And the issue now in that we are, dabbling with is, can we de-intensify the treatment to achieve the same result but give less of a toxicity or sequela of treatment? Again, the same argument comes in. One size fits all is not applicable in HPV cancers. We have to tailor the treatment to the disease, HPV positivity, the stage of the disease, and tailor the treatment according to the disease, according to the tumor and the patient. We don't do the same operation on every patient, right? If the tumor is small, we do a smaller operation. If the tumor is big, we do a big operation. And we tailor the operation to the tumor. Why can't we tailor radiation to this tumor? The dose may be less, the ports may be less, you don't have to go through and through the opposite side. So things have changed. Focus in HPV associated cancer today is not curing more people. We can cure the most, but reducing the side effects of treatment, maintaining the same cure rates.
And Dr. Shah, since you're talking about the treatments, can you share some of the latest breakthroughs or treatments that are making a real difference for patients with head and neck cancers? And also, when you're talking about this, since you began your conversation with understanding the ethnicity, etc., is precision medicine and genomic profiling transforming the treatment approaches when you're talking about the latest breakthroughs?
To call it transforming is a bit premature, but the indications are that it will probably transform. The biggest news in systemic treatment of cancer in the last 30, 40 years is immunotherapy. But that doesn't mean you go to the shop and buy a immune checkpoint inhibitor and start taking it. We are not there yet. There are a substantial number of trials ongoing, and we need to wait for the results of those trials to precisely know where we should employ immunotherapy, which immunotherapeutic drug for which particular mutations in the tumor. So immunotherapy is great based on early experience, but we need to define where, when, how, and for which tumor. And for that, we need the genetic profiling of the tumor, the immune checkpoint inhibitor drugs associated with those immune profile, and then employ the drug when you will see dramatic responses. In the current trials, we see dramatic responses in maybe 15, 20 maybe at the most 25% of patients. But a majority, 75%, do not respond. So the issue is not to celebrate the 20% who are responding and whose tumors melt away. We should be concerned about the 70% who are not responding. Why they are not responding? Are we giving them the right immunotherapy? They have the right immune profile, or we are trying to fit a round box in a square hole? So a lot of work needs to be done. I will give you an example of a multinational clinical trial which was presented just last week at the American Association for Cancer Research. The trial was conducted by the drug company Merck. It's called a Keynote 689 trial, which showed that 15 to 20% of patients have reduced risk of dissemination of disease. Great news. We have never seen something like that before. But it's too premature. Yeah, it's only 15 to 20%. We need to look at 90 to 95%. And that's where the work needs to be done.
And Dr. Shah, the treatment for these cancers can impact things like speech, swallowing, and even appearance. How do you help patients navigate these uh, tough choices while preserving their quality of life? And how do you balance the treatment efficacy with the quality of life, especially when surgeries and radiation can impact the speech and swallowing and appearance for the patient?
So, unfortunately, head and neck is the most visible part to the society. I can do a huge operation in your abdomen and nobody will know. You put on your jacket and you're looking healthy. I
Correct.
do a small operation on the skin of your nose and everybody is going to ask you, hey, what happened here? What happened here? Now extrapolate that to big operations requiring removal of the nose or the eye, jawbone, swallowing passage, voice box. It clearly impacts on the quality of life. So in treating patients with head and neck cancer, cure of cancer is not the only focus. Cure of cancer and preservation or restoration of function and form is crucial to improve quality of life. So living longer is good, but living longer in misery is not good. Living longer with better quality of life is the aim and goal. Therefore, the operations have become smaller, as I just mentioned earlier. You give neoadjuvant treatment, meaning if a patient is facing a big operation for a big tumor, you give either drugs or drugs combined with immunotherapy to reduce the size of the tumor, hopefully reduce the extent of the operation, and thus minimize the surgical morbidity of the operation. Add to that reduced dose of radiation, better methods of radiation delivery, IMRT or proton beam treatment, which protects normal structures around the cancer, will minimize radiation effects. And reducing doses of chemotherapy will reduce toxicity of the drug. And if you do suffer with any of these sequelae, head and neck cancer is not a one person treating the disease. It requires a whole team of doctors. A local doctor in a community hospital in a village he may be capable of doing an operation, but he'll be a miserable failure because he doesn't have the team to work with him. To treat a head and neck cancer, you need a surgeon, a radiation oncologist, a medical oncologist, a radiologist, a speech and language pathology person, a rehabilitation specialist, a reconstructive surgeon. All of these people are necessary, in addition to which you need a social worker who can put families of head and neck cancer patients together to see their perspective of what they are suffering because of the patient and how can they help the patient recover. At Memorial Sloan Kettering, we also have a program called PRO, Patient Reported Outcomes. We may think we did a great operation and cured the cancer, but you ask the patient, He said, doc, I resigned from my job. I don't go to clubs anymore. I feel like a lost soul. Most of the times I'm home. That should not happen. So we should see what the consumer is feeling and appreciating from what you have done. It's a very robust program because it tells us what is the expectation of the patient and how can we modify their expectations and make them realistic or change our methodology to address their issues before they happen.
So this is very interesting when you were talking about that how it's a collaborative treatment process, not just one doctor's this thing. And second is it's not just treating the condition, but also look at what impact it could have on somebody's day-to-day life. Uh,
Absolutely.
yeah. And Dr. Shah,
Fortunately, we now have the ability, from a surgical standpoint, to reconstruct anything on the face. We can bring tissue from the leg, from the arm, from the hip, bone, skin, muscles, soft tissue, fat, and rebuild
correct.
what God gave you.
Right,
And microsurgical reconstruction techniques have improved so much that we can essentially restore the face.
right. So, Dr. Shah, we were talking about symptoms, then we were talking of how the treatment happens. Uh, you also spoke about how genomics could create an impact. Now, are there any habits or lifestyle changes that can significantly lower someone's risk of developing the head and neck cancer? So, let's talk about the prevention.
So sadly enough, India is the capital in the world for mouth cancer. Nothing to take pride of, but the largest number of cancers in the mouth, buccal mucosa, cheek, and the gum occur in India. From anywhere in the world, from North Pole to South Pole, and from New Zealand to Alaska, India is the capital of oral cancer. Why? Why? Because tobacco chewing, pan masala, gutkha, smoking, and alcohol. You add up all this, it's like adding fuel to fire. So the prevention of oral cancer is very easy and very cheap. In fact, if a young man at age 15 or 16 does not start chewing tobacco or eating pan or smoking, by the age of 45, he would have saved enough money to send two of his children to the best colleges in India, would have lived a happy life owning his own home from the money saved from buying tobacco and cigarettes. So for
Right.
India, it is very simple and very cheap.
Mhm.
Prevention of oral cancer in India is feasible, and that should be the highest priority. And the education about the risks of this begins in, I wouldn't say kindergarten, but in lower school
Right.
before they get their hands on their first BD.
Mhm. I think you've nailed the head because a lot of awareness needs to happen at an age where it gets imprinted as a normal in their life rather than trying to teach them something not to do when they've already past that age.
I would expect an 8-year-old child to come home and say, Papa, please don't smoke because you can get cancer and your smoke can give me cancer.
Right. That's
And
that
that will work best than any other medicine you want to take. Your
absolutely.
little 8-year-old girl telling you, Papa, don't smoke. And what more do you want?
Absolutely. I think that's what needs to happen. And Dr. Shah, we often hear about multidisciplinary. I know you've spoken about it briefly earlier, but we often speak about multidisciplinary care. What does that look in practice for head and neck cancer patient, and why is it important? Can you elaborate on what you shared with us earlier?
Sure. So prior to 1960, the only treatment for head and neck cancer was surgery. But we had come up to the zenith of surgery. We could chop somebody's head off and cure cancer, but the patient won't live. So we had done the maximum of the biggest radical operations, and the cure rate did not remained stable. So we had to add something to improve upon surgical cure. So the first attempt at that was a combination of surgery and radiation, given either before the surgery or after the surgery. And it did show that the recurrence rates after surgery were improved. They came down. So here was the first observation that combining two makes it better than employing one alone. By that time, new drugs were coming into the picture, and the introduction of cisplatinum in the mid 1970s uh, gave us an observation that in those patients where these drugs work, they worked beautifully. Tumors melted away. In some patients, they disappeared, avoiding surgery altogether. Unfortunately, it occurred in a very small number of patients. But here was a concept that maybe we should add a third element, the drug, in addition to surgery and radiation. And that is what led to the concept of preserving function. The biggest trials of preserving the voice box, larynx, took place in the United States in the 1980s, called the Veterans Administration Larynx Preservation Trial. In patients whose cancer would have required removal of the voice box, they received the drug, and if they showed a good response, they received only radiation, no surgery. In 64% of patients, we did not have to do the surgery. They had a functioning voice box, and all they required was treatment with chemo and radiation therapy. So now, fast forward to the 90s, we realized that instead of giving sequential treatment of drug, then radiation, and then surgery, if you combine the drug and radiation concurrently, it's even better. And that brought up the organ preservation rate up to 80%. 80% of the patients who would have required laryngectomy are able to preserve their voice box using drug and radiation given concurrently. And that has become the standard of care. Similarly, with the development of new drugs and now with immunotherapy, we are focusing at not only improving cure rates, but reducing the intensity of treatment. Less surgery, less radiation, less chemotherapy to achieve the same result, but better quality of life.
And Dr. Shah, you are running an association society, and you have, like you said, 70 societies from across the world, which are now a member of the society that you have established. I'm sure you're in touch with the specialists from India as well.
Yes,
What,
indeed.
what, in your opinion, is about the Indian healthcare system? Do you think we are now advanced enough to match with what the practice happens across the world? Because you left India way back in 1967, and from then, the impression that you have of Indian healthcare from that time to today, what do you think about the Indian healthcare delivery system?
So the short answer is absolutely yes. And the longer answer is yes, I left India in 67,
Yeah.
but I have been visiting India not for family reasons or social reasons, but for professional reasons, literally every year, every other year. And
Lovely.
I've seen the progress, by leaps and bounds. You have world-class surgeons in India delivering the same surgical care that they would get in New York today. In major cities, Bombay, Delhi, Bangalore, uh, Chennai, Kochi, Chandigarh, Calcutta, you have phenomenal surgeons. The issue is we need to now purvey the philosophy of developing teams, multidisciplinary teams, so that the surgeon only is not the player. I mean, you don't play cricket with only the batsman. You need a bowler, a wicket keeper, and fielders, right? You have a team of 11, if I remember correct,
Yes,
to
sir.
play cricket. So
Yes.
think of treating head and neck cancer is a cricket game. You require a batsman, you require a bowler, you require a wicket keeper, you require filters. And that
Absolutely.
means you need radiation oncology, medical oncology, reconstructive surgery, dentistry, rehabilitation medicine, and support services, including social work.
Absolutely.
That team is the success or is the essence of success in treating head and neck cancer. You want to eradicate and treat cancer, but you want to deliver the same quality of life to the patient that he or she enjoyed before the diagnosis of cancer.
Dr. Shah, thank you so much for your time. Uh, you know, Specifically to the head and neck cancer, when I heard you talk about that it is not just about treating the cancer, you're talking about the function and the form which could improve the quality of life or quality of the mental makeup about the quality of life of the patient. That is so, so important.
Well,
Dr.
this is the essence of Memorial Sloan Kettering Cancer Center. For over 125 years, this institution has uh, trained and generated generations of specialists who are all over the world. And our mission is not just treating cancer, but pushing the frontiers with research and training the young to disseminate and take the message home from wherever they come from. I spent my entire career at Memorial Hospital doing the same. And this is what keeps me here because uh, there is no better place to be treated, to be trained, or to be finding new avenues. This is Memorial Sloan Kettering Cancer Center.
Thank you so much, Dr. Shah, for sharing your deep insights and talking about the evolving landscape of the head and neck cancers. Thank you so much for your time.
My pleasure. Have a good day. Bye bye.